Hello everyone, my name is Dr. CIMMY Augustine. I'm the Department of Prosthodontics, Mahi Institute of Dental Sciences and Hospital. Today's topic of discussion is maxillary defect. So, the subspecialty of prosthodontics, which deals with the maxillary or the maxillofacial defects in general, is maxillofacial prosthodontics. So, maxillofacial prosthodontics, as I said, it is a branch of prosthodontics which is concerned with the restoration and replacement of stomatognatic and craniofacial structures with processes that may or may not be removed on a regular or elective basis. So, the various maxillofacial defects are there. Like it can be maxillary defects, it can be mandibular defects, it can be velopharyngeal defects, can be extraoral defects like your auricular defects, nasal defects, ocular defects, lip and cheek defects. So we will be dealing with maxillary defects in this seminar. So the maxillary defects, that means a defect of the maxillary region. It can be because of congenital causes, it can be because of acquired causes. Congenital causes means the patient either has a cleft lip or a cleft palate, and acquired means patient has undergone maxillectomy. It could be total or it could be partial maxillectomy. Now, first dealing with the congenital maxillary defects. The most common defects that we see are cleft lip and cleft palate. The other defects could be Peary-Robin syndrome and hemifacial microsomia. So as you all know, in Peary-Robin syndrome, the patient has micrognathia, cleft palate, glossoptosis. Okay? And hemifacial microsomia means one side of the face is underdeveloped. Now, coming to cleft lip and cleft palate. Cleft lip, it occurs due to the improper fusion of the frontonasal process and the maxillary process. It could be unilateral or it could be bilateral. In Mohr syndrome, a patient has median cleft lip. Now, what could be the etiology? It could be either because of some infections, drugs like phenytoin or barbiturates, poor diet, hormonal imbalances, or genetic factors. Now, cleft palate can either involve the anterior palate or the posterior palate. So, anterior cleft is because of a defective development of the primary palate. That is a mesenchymal deficiency. Whereas the posterior cleft, it is due to the defective development of the secondary palate. That is improper fusion of the palatine shelves. Now, as you see in this figure, 1 represents the intermaxillary process, 2 is the palatine process of the maxillary processes, and this 3 is the maxillary process. So, primitive palate, that means it is the primary palate, the anterior palate deficiency is due to the improper fusion of the primary palate. Whereas the posterior clefts, they are due to the improper fusion of the palatine processes with the maxillary processes. Now, if we see the incidence rates, according to a study, it has been seen that patients with cleft lip, with or without cleft palate, they are 14 per 10,000 live births. This is the incidence rate. Whereas patients with cleft palate, they say that the incidence rate is 4 per 10,000 live births. Now coming to the classification of cleft palate. There are various classifications of cleft palate. We will be studying the Hughes classification. So according to Hughes, class 1 is a defect which involves only the soft palate. So it can also be a submucous cleft. That means it appears normal, but there is a cleft. Class 2 is midline cleft, which involves the cleft of the hard and the soft palate. It's up to the incisor foramen. So it's present only on the posterior part of the palate. Then is a class 3 defect, which is a complete unilateral cleft of the hard and the soft palate and the lip and the alveolar ridge on one side. Class 4, that is a complete bilateral cleft of the hard and the soft and the lip alveolar. So studied that who has given 4 classifications. According to that, class 1 is cleft, which involves a soft palate. Class 2 is it involves a hard and soft palate up to the incisor canal. Class 3 is a unilateral, complete unilateral cleft of soft and hard palate and the lip alveolar ridge on the side. Whereas class 4 is a complete bilateral soft and palate, the lip and the alveolar ridges on. Now, in this image, a child has left lip. So what we had done is we had made an impression of this of patient and we got a pass from that, and we have given feeding appliance. So when a child suffers from right lip or left palate, the main problem given is feeding, because whenever the child sucks in milk, it will either enter the nasal, it can go into the nasal cavity. So the child may suffer choking. In order to prevent that, we give a feeding appliance. Now, in patients who have a cleft lip, adult patients, they will have difficulty in speech because of this cleft. So we can use a speech bulb prosthesis. This will aid in speech. This was all about the congenital maxillary defects. Now we come to acquired maxillary defects. So as the name says, acquired maxillary defect. This is because of a surgical resection. Surgical resection may be because of a tumor. So, the most common tumors of the maxillary region are dermal carcinoma, salivary gland tumors, malignant mesenchymal tumors, and non-neoplastic tumors like gland, vaginous granulomatous, mycosis, and aspergillosis. All this can cause surgical section. Now, as I said, maxillary defects could be because of either a maxillectomy or a partial maxillectomy, which has been done. It was Dr. Muhammad Armani presented the first published system of classification of post-surgical defects. So this classification is based on the relationship of defects to the remaining and the frequency of occurrence of the defect. So according to Dr. Muhammad Armani, class 1, that is Armani's class 1 defect, is a unilateral defect. This involves half of the arch and adjacent paratangent. This extends to the midline, and usually all the teeth on the affected side are missing. Now, class 2. Armani's class 2 is a unilateral defect again, and it involves only one side of the arch. So usually the teeth posterior to the canine are missing. Whereas in class 1, all the teeth of the affected side were missing. In class 2, it is the teeth which is posterior to the canines which are missing. Class 3 is a defect which involves the center of the palatine shelves. Usually all the teeth are present. So only the defect is there in the center of the palatine shelves. Then we have class 4. This is a bilateral. This involves one side of the arch along with the entire maxilla. So usually all the anteriors along with the posteriors of one side are. Now, class 5 defect, that is a bilateral posterior defect, which usually all the teeth anterior to the second premolar are present. Then is class 6, that is a bilateral anterior defect. Usually all the teeth anterior to the second premolar are absent. So just rising once more. Class 1 is a unilateral defect involving half the arch and the adjacent palatine shelves, extends to the midline. All the teeth in the affected side are missing. Class 2 is a unilateral defect. All the teeth posterior to the canine are missing. Class 3 is a central defect, that means it involves the center of the palatine shelves. Class 4 is a bilateral defect and it involves one side of the arch along with the entire premaxilla. All the anteriors along with the posteriors of the side are missing. Class 4 was a bilateral posterior defect, anterior to the second premolar. And class 6 was again a bilateral anterior defect. All the teeth anterior to the second are missing. Thank you.